Hello, class, and welcome to Chapter 10, Rhythms Originating in the Ventricles, Lecture Part 2. We're going to talk about ventricular tachycardia, or otherwise known as VTAC. VTACs are irritable ventricular focus, which has abrupted the sinus node to become the pacemaker and is firing very rapidly, which means that the heart rate will be anything over 100 beats per minute. So if you're doing your R-to-R interval and its regularity can be somewhat regular but slightly irregular, that would be a determination off a base of what you say or how you perceive it. But most of the times it will have some regularity to its rhythm. So if you're R-to-R and you do your 1500 and you come out with 101, then you have some type of VTAC. You usually don't have any P waves because it is going so fast, and being that the ventricles are the last resort, you usually won't see any P wave forms because it's your ventricles that are taking over as the main pacemaker now. So being that it doesn't automatically activate your atriums in order to perceive a P wave. So if there are no P waves, therefore you cannot provide a PR interval. But you will have a QRS, and 9 out of 10, if you have a VTAC, your QRS complexes or your QRS waves will be wide and bizarre. So your QRS interval is going to be greater than 0.12 seconds wide. So if you come out and your QRS is, say, 0.16 seconds, then you know it's a wide and bizarre QRS. Your T wave is always going to show up as the opposite of what your QRS is. So if your QRS is in the upward deflection, guess what? Your T wave is going to be in the downward deflection, and vice versa. If your QRS is pointing down, your T wave will be up. Some causes of VTAC can be due to heart disease, hypoxia, hyperkalemia, and the reason, as we go along further into EKG, you'll understand how hyperkalemia, you can tell if somebody's hyperkalemia, is you would look at their T wave. They might be hypo magnesium, or it could be caused by stimulants. Some adverse effects that can be caused by a VTAC is you can go into shock, you can become unconscious, or you can expire. Death. Expire. That's the word. Expire. That's what you'll hear in the hospital. Expire. Some treatments that they do administer for those who are in VTAC, they might be given lidocaine if the patient is stable enough to sustain it, or they might do cardioversion if the patient is unstable but still has a pulse. If the patient doesn't have a pulse and they are unstable, then they would do defibrillation on that patient. Or you can treat the cause by supplemental potassium, or giving them oxygen treatment, or they might be given a defibrillator, an implantable defibrillator. And if you take a look at this example, this is an example of a VTAC. As you can see, it's going in the, there's really not a defined Q, but there's your R, S, and then your T is right here. R, S, T, R, S, T, R, S, T, R, S, T, R, and it's going super fast across the screen. And you have wide and bizarre QRSs. The next rhythm we'll talk about is called the touche de point, or as in French, is the twisting of the points. It kind of looks like a DNA strand if you look at it, because it kind of like if you ever took a ribbon and you kind of twisted it, that's kind of what it looks like. We call this type of rhythm a polymorphic ventricular tachycardia. This is another name for it. So if you can't say touche de point, you can say it's a polymorphic ventricular tachycardia. And polymorphic just means it kind of goes like an accordion in and out. It goes from tall to short, tall to short, tall to short. Polymorphic. It's usually not a long burst, but it can lead to VFib if not corrected. With a Tuesday point, its rate is anything over 200, meaning it's going super fast. Its regularity can be either irregular or regular. It's one or the other. It just depends on how steady it's pulsating out or how unsteady it's pulsating out. So therefore, you will not see any P waves. You will not have a PR interval. Your QRSs are wide and bizarre. They will be greater than 0.12 seconds. And sometimes it's very hard to measure them because they are going in a twisting point. They are going from long to short, long to short, kind of like radio waves and frequency waves. Frequency waves. If you ever seen it, you get these tall peaks when somebody's talking, and then when you have dead silence, you have little peaks, and then when they talk, the peaks go up high. That's kind of what a towards the point looks like. Your QT intervals are long or prolonged before the towards the point happens. And of course, your T waves are always going to be in the opposite direction of your QRS, which is what most ventricular rhythms do have. Whatever way your QRS is facing is the opposite way of what your T wave is going to be facing. Right. Some causes of a choose the point is antiarrhythmic medicine, hypokalemia, hypoxia, hypomagnesemia, or heart disease. Some adverse effects to this rhythm is you can go into shock, you can become unconscious, or you can expire. Because remember, ventricles is the last pacemaker and it's the last stand before the heart automatically just says, okay, enough's enough, I quit. I'm not going no more. I'm done. Treatments that can be given for people who suffer with choose the point is they might be given supplemental magnesium. They might have to go through electrical cardioversion, or they might be placed on oxygen. Sometimes they will also have a defibrillator placed into their chest surgically to kind of jumpstart their heart. And here's an example of a choose the point. As you can see, you have big waves and then it goes small and then it goes big again and it goes small. But if you turn it on the side, which I wish I could do this, in here is rotated. If you turn it on its side, you can pretty much see it has a twisting effect, almost like a DNA strand or a ribbon that's twisting. Ventricular fibrillation, or VFib. This is just 100 of impulses that are in the ventricle. They're firing all at one time. There really isn't any much room for depolarization because it's firing that fast. So you kind of have that wiggle effect to where you have it. Pretty much your heart electrical system is in chaos. It's all over the place. So you really can't count a rhythm because it's firing just that fast. It's going too fast for you to even count a rate. So therefore it will not have any type of regularity. You definitely will not see any P waves. And if you do happen to see a QRS, which don't let it fool you because there aren't any and there's no T waves. So this is like the easiest rhythm to interpret because there's nothing you have to calculate because there's nothing you can see because it's going too fast. Some causes of a VTAC are due to MI, myocardial infarction, hypoxia, hyperkalemia, drowning. Yes, if you drown, you go into VFib. Drug overdose, and um, accidental electrical shock. That's why it's very, you're not supposed to pay court where wires are exposed because of that. Hence why we always check our EKG machine so we don't accidentally send somebody into a VFib by electrocuting them. So that's why we check our EKG machine to make sure there's no frayed or exposed wires in it. The most common arrhythmia that occurs in a VFib is within the first hour after MI has happened. So basically what is happening is once a person goes through a stroke, your heart is weak. So it might go into VFib. So it's usually this is the make or break it with people who have had a stroke. This is the make it or break it period. Hopefully they make it to the hospital in time before the VFib just completely stops the heart automatically, without a doubt, just without. So once they make it into the hospital, they can pretty much hopefully reverse the VFib before it becomes too deadly and the patient expires. So if they don't, this is when it causes the patient to expire. Some adverse effects to a VFib is you can have a profound cardiovascular collapse, meaning all your valves collapse or your arteries collapse within the heart, and the patient is pretty much expired. Some treatments you can use for VFib, if it's not too late, you can do defibrillation, you can give them lidocaine, oxygen, of course CPR, epinephrine to stop it. So this is what a ventricular fibrillation looks like, or VFib. Is just a whole bunch of lines straight across, a whole bunch of spikes that have no rhyme or reason. It's just going QRS, 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 QRS. If you can distinguish, it has a QRS. But most of the time it has a wave, a flutter effect, or a wave, as you can see what it looks like here. Astole. Astole is just a flat line EKG, meaning everything has ceased and desist to work. Your SA node's not working, your AV node's not working, your ventricles have stopped working. All pacemakers have failed and stopped. Therefore, you have nothing, 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 nothing. And some causes of an astole is due to hypoxia or profound cardiac or other damage that has been done to the heart to where it's almost irreversible. Adverse effects are usually terminal rhythms, meaning there's nothing there unless they can resuscitate you back from an astole. But once a patient goes into astole, they usually say, call it. That's how they say, call it. And that's when they give you your date and time of expiration. Some treatments that can be administered if a patient does go into astole is, of course, CPR, epinephrine, oxygen, which they'll have all that attached to you. They'll pull out this big old needle and fill it up with epinephrine and stick it straight to your heart. And all this time, your body is also on oxygen, and they're also doing CPR, or they're giving you electrical shock if you're in the hospital. Sometimes it can be reversible if it's caught in time. And this is what an A-stall rhythm looks like. It's not like what the movies say it is, a flat line, because you got to remember, you do have some electrical pulses that are still transferring out. They're just not doing anything anymore. So you kind of have this wave effect. But there's no defined QRS, or there's no defined P. It's just nothing, no activity. It's just a wave, a smooth ocean wave going down. Sometimes you have what they call a P wave A-stall, meaning your sinus node is still firing, so it hasn't stopped yet. It's still firing. It's just everything else is not connecting through due to the fact that your ventricles may be damaged or too damaged to respond to the stimulant that the SA node is sending out. Or you might have a block somewhere within your conduction pathway that's not signaling for your AV junction to carry out the impulse to the ventricles. So you have atrial depolarization, but you don't have any ventricle depolarization. So you'll just see a line of P's and no QRS that are followed. So you have a lonely P that has now left its QRS. Because other than that, they're usually married to each other. And this is what a P wave A-stall looks like. It's just a whole bunch of P's all alone with no QRS to follow. Pacemaker rhythms. Pacemaker rhythms are electrical devices that are inputted or attached to a patient who may have suffered from an MI, and one of their valves are not working properly, or that particular artery is damaged or closed off and it's not receiving signals like it should be. So they'll implant a pacemaker to automatically send out a shock whenever that particular pacemaker doesn't respond to a stimulant. So they'll automatically stimulate it for them. So you can either pace out the atrium or the ventricle or both, which we call dual. If it does atrial and ventricular, we call it a dual pacemaker. Whenever a pacemaker sends out a signal, it shows up on the EKG as a vertical spike where it's recorded. So if you have a ventricular pace, it'll spike right before the QRS forms, and usually it perceives a wide QRS if you have a ventricular spike. If for some reason you have an atrial spike, it'll follow the spike, and then a P wave will follow after the spike. But if you have dual, you have one before the P and before the QRS. So it kind of sandwiches the P wave in between the two. So if you look at figure 1017, A shows a ventricular pace, meaning that the SA node is damaged. So in order for your heart to for your ventricles to contract, it'll send out a pace, and then your ventricles start to contract out. And as you can see, it is a very wide QRS. If you look at B shows a dual chamber pacemaker or pacing. If you can see, there's a spike before the P is formed and a spike before the QRS is formed. Pacemaker rhythms are very easy to identify. You just look for the spike in the wide and bizarre QRS. Okay, I'll work out a couple of rhythms with you to kind of get you started. As you can see, some of them you can pretty much eyeball and see what they are. This particular rhythm right here is automatically just by looking at it. It's a agonal rhythm. This is an agonal rhythm right here. Now, if you just write the interpretation and you don't figure this out, it's understandable because it's pretty much eyeball right here. I already know it's going to be greater than the QRS interval is going to be greater than 0.12 because it's a wide and bizarre QRS. There is no P, there is no P wave, so there's not going to be a PR interval. Its heart rate is very slow. From here to here, you can tell. So if you just put the interpretation, I'm not going to count for the calculation, but just for practice, I want you to make sure you have everything done. All right, this particular rhythm, if you look at it really good, you have big spikes, little spikes, big spikes, little spikes, big spikes, big spikes, little spikes, little spikes. So you really can't figure out this. I mean, you can. You can find one perfect QRS to where you can figure out your QR interval. There's definitely no P's. There's definitely no PR interval. If you do an R to R, there's no more than 3 or 5, maybe 6 in between. So you know this is a, and I can't spell it either. So if you get it close, I know what you're saying. This is a two-step point. All right. Next rhythm. Can I get one I can solve? Aha! All right. So here we go. R to R. We have R to R, R to R, R to R. It looks regular. Oh, first question. Are there any QRSs? Yes, and they're narrow. Yes, and they're narrow. Regularity, regular with a premature beat. Because here's your premature beat. Heart rate is 5, 6, 7, 8, 9, 10, 11, 12. 1500 divided into 12 gives me 125. And the reason why I didn't write regular with a premature beat is kind of hard to write it on a computer. Are there any P waves? Yes. Yes, and they are married to the QRS. And I can put yes, and I can put yes. It's regular. Let me do this right. With premature beat. Premature. Okay. PR interval. Let's see. We go from here to here. I count beginning of P here to here. 1, 2, 3, 3 times 0.04, which gives me 0.12 seconds. All right, QRS, if I do it from here to here, I have 2, 3. And I have my glasses on right now, so I really can't see that good. 4, and we came out with 0.12 seconds. So this is a sinus tachy. So sinus tachy. Sinus tachy with a PVC. Ta-da! Okay. So let's take a look at the next one I'm going to do. Well, guess what we just found? A spike. So this would be ventricular spiking or pacing. Ventricular pacing. Right? So this concludes chapter 10, part 2 lecture. I hope this clears up everything that might have been missed in the first lecture. You will have your chapter test on this very soon. Everything should, if you have any questions or anything, please text me before you take the test, and I will try to clear up anything you might have questions on. I do thank you and have a nice day. Bye-bye.